As we go into our second module for this week, talking about the pharmacotherapy for COPD, remind you to certainly review previous lessons for asthma. For COPD in particular, we will be talking in brief about some of the pharmacology, but I'll be asking you to review your notes from the asthma section. But we will be talking about one or two agents that are new specifically for COPD. We'll go through the dosing and monitoring, other important aspects related to monitoring, and the progression of this. There are two different sets of guidelines for providers who are managing patients with COPD. One is the 2004 guidelines from the American Thoracic Society, Standards for the Diagnosis and Management of Patients with COPD. And then the GOLD guidelines from that are updated on an annual basis. So I do have the link in Blackboard for the most recent guidelines. The Global Initiative for Chronic Obstructive Lung Disease, that's where the GOLD acronym comes from. So they have a lot of helpful information, including like a provider's summary or packet that is easy to use and easy to find some of the different charts and tables that you might need when you're taking care of your patients. So as we start to talk about COPD today, I'm just honing in on the drug portion. I need you to have reviewed the guidelines as well as the information from the last lecture related to the various inhalers that can be used, since many of them are used for both asthma and COPD. There are the objectives as well for this whole week's module that is, so what is COPD? It's a lot of different symptoms. Previously it was broken down a lot into patients who had emphysema and patients who had the chronic bronchitis. And so you had the tall, thin, smokers with the emphysema versus the chronic bronchitis, the coughers, kind of the larger barrel-chested, or with emphysema. And then we had asthma, because we do know that sometimes asthma is also prevalent in patients who have COPD. But COPD is its own separate disorder, and it is irreversible airflow obstruction. So if we talk how it differs from asthma, which we think of as reversible airflow obstruction and constriction. COPD is mainly from cigarette smoke. That's the number one cause. And so the more we can do to help with that, and we'll be talking about that in another lecture, specifically just smoking cessation. But cigarette smoke plays such a large role in the development of COPD. And that really goes on to cause destruction with the macrophages and the epithelial cells, and in the end, the lungs, the alveolar areas are destroyed, and your lung function declines. So it is a slow and steady decline, as you'll see in a future chart. Asthma, on the other hand, primarily allergens, which could be cigarette smoke, but many other things that come into play that affect more the mast cells and the epithelial cells. So again, we have some medicines in asthma where we can see mast cell stabilizers being used and whatnot. Mainly eosinophils with that allergic response being stimulated. And that's where the bronchoconstriction and the airway hyperresponsiveness comes in. So as you can recall from our asthma discussion, we had several agents that work on the bronchoconstriction as well as that airway hyperresponsiveness, so that the patients don't react so much so violently to the allergens that they're coming into contact with to have such severe airway restriction. So COPD, typically you're going to have that onset in midlife after many years of smoking as the lung function declines from the damage. Again, usually asthma is diagnosed in childhood or at least earlier in life. COPD, it is a progressive disease. It certainly seems to worsen over a number of years. Asthma patients can be good one day, next day having those symptoms again from the triggers. With COPD, you're going to have that history of tobacco smoking or some type of smoke. You're going to have a lot of dyspnea during exercise because the airways, the lungs just can't fill up with air and do the proper air and blood exchange. And like we said, it's largely irreversible. Sometimes there's some component of asthma and COPD where there is some reversibility, but primarily it's irreversible. And you can see the reverse, obviously, with asthma. It's mainly a reversible airway limitation. There's a lot of times a family history. And again, the allergy component is often present, whether it's eczema, rhinitis, and allergy symptoms. So again, as we talked about kind of that difference with that first picture with emphysema or obstructive bronchitis or bronchiolitis, as they call it, there's two different kind of things at play. The small airway disease, where you're going to have the airway inflamed and problems with the airway constriction, and then the emphysema, the many years of smoking really causing just the destruction of the alveolar mechanisms. So if you look at this chart, you can see we have the age down at the bottom, starting at age 25, which is pretty rare to be diagnosed with COPD, typically, like we said, midlife by age 50 or so. On the left hand, the y-axis, we've got the FEV1, that forced expiratory volume at 1 second, and the percent of predicted. And so we have that line going down that really talks through or shows us, demonstrates that movement from stage 1 to stage 4 of COPD. And patients may stay in stage 1 for quite some time and not even have many symptoms. So like we said, it's mainly asymptomatic. They might be a smoker and you're talking to them at each visit about quitting smoking, but they don't really see that they're having trouble exercising. Maybe they're not exercising, but not trouble breathing. And so unless they're really pushed with exercise, they're going to be mainly asymptomatic. And then as the lung function declines, then that's where you get into more of the symptoms presenting. And, your 50-year-old, I can't play, pick up basketball at the gym anymore, that progressive dyspnea. And anytime the infections kind of come on, and that's what you can see with the red arrows coming in, you can have exacerbations or bronchitis infections, other lung respiratory viral infections that come in. And each time that happens, that's just going to worsen the lung function. It's really hard to recover from that. You don't really see the spike back up to previous levels. So the more that we can limit those viral and bacterial infections, the smoke, we're going to limit those exacerbations, and we're going to limit the decline, or at least lengthen out that decline so that somebody can stay in stage 2 perhaps a little longer. So patients who have more exacerbations are going to progress more rapidly. So building up to that, what do we want to do for patients with COPD? We're not going to cure it. We're not going to reverse those symptoms. What we're trying to do is, again, reduce symptoms, help them be able to exercise, improve their health status, feel like they can still be active to whatever degree possible, and then reduce their risk of exacerbations, their disease progressing from those exacerbations, and then ultimately reducing mortality. The cornerstone, and the GOLD guidelines will verify this, the cornerstone is to stop smoking. This is from the GOLD guidelines, smoking cessation has the greatest capacity to influence the natural history of COPD. Healthcare providers should encourage all patients who smoke to quit. We have another lecture I'll be reviewing next for smoking cessation specifically, but that has to be the number one thing that patients do to help their cause. if they continue to smoke, they're going to get bacterial or viral infections. They're going to have exacerbations, and they're going to move faster down that path to needing oxygen and ultimately death from their respiratory problems. As much as we can focus on smoking cessation, the other important feature is to help the patients be as physically active as possible so that it can help maintain their lung function. And patients may have to undergo pulmonary rehabilitation after an exacerbation and as they progress. Vaccines are also important. As I mentioned before, I teach vaccines to our patients, so I'd like to certainly hit on those with you. Again, patients with COPD should be getting their influenza vaccine annually. It should primarily be the inactivated intramuscular vaccine. The live attenuated intranasal one is really only up to age 49. So most of our patients with COPD are going to be over that age, and so it's the IM. And then pneumonia. This is where it gets a little tricky, and it's also not, your textbook is inaccurate in this area. So just be aware that as with asthma, COPD patients need that PPSV, that polysaccharide vaccine, the PPSV 23, between the ages of 19 to 64 because they have that chronic lung condition. And then it's not true that they should have a PPSV 23 every 5 years. That is not true. I know when it first came out, there was the thought that patients needed a booster every 5 years or every 10 years. The guidance is one between the ages of 19 to 64 if you have lung disease like COPD or asthma, and then a second dose once the patient's over the age of 65. And it needs to be at least 5 years from the first PPSV 23. So if you have a 50-year-old diagnosed with COPD, still smoking, working with them to quit, they get the PPSV 23 vaccine at age 50, they're good until the age of 65. Then they get a repeat PPSV 23. On the other hand, if you have a patient who's 62, comes in to see you, and you give a PPSV 23 because that's the first time they've had it, at age 62, then when they turn 65, that's only been 3 years, you don't give them another PPSV 23. They got their first one at 62. You need to wait at least 5 years. So at age 67 or beyond, that's when you give the next PPSV 23. So sometimes, like I said, that gets confusing, and the thought out there was every 5 years, every 10 years, and that's not true. The FDA and the ACIP have gone and complicated things for all of us and also now recommended the PCV 13, so Prevnar 13, for all patients age 65 and older. And obviously that's probably going to be a lot of our COPD patients. So where we have to be careful, and you can always talk to your trusty pharmacist about this, but it's recommended then that a patient, when they turn 65, they get the PCV 13, wait a year, and then their PPSV 23 when it's time to get that. They want that year in between. It's not preferred for patients to get them both at the same time. You can go less than a year, but just with what Medicare pays for, they pay for one pneumonia vaccine a year. So until they change their guidelines, that's what ACIP has gone with. So again, just recognize that patients do need both of those vaccines. All right, so for COPD treatment, we're going to talk about the different bronchodilators. So we go through the beta receptor agonists that you should know and love, our anticholinergic medications, which we know, and the xanthine derivative theophylline. And then we will also talk about corticosteroids and something new, phosphodiesterase 4 inhibitors, as well as briefly talking about oxygen. So for the beta receptor agonists, nothing new. You need to review from the asthma lecture those slides that talked about how do they work, what are their adverse effects, warnings, and precautions. Just keep in mind that, especially for the beta receptor agonists, we talked a lot about the cardiovascular side effects, and something that may be fine in a 19-year-old with asthma to be taking albuterol on a regular basis. When we're dealing with a 65-year-old who also has had a heart attack, that's when those cardiovascular or CNS side effects could become more important. So just recall that for that older population with COPD. The dosing is going to be a little bit different just in how it's provided for patients. The albuterol is the same, 2 puffs every 4 to 6 hours, and it's certainly an acceptable option in the lower stage of COPD. You can use the long-acting beta agonists, 1 puff every 12 hours. Recall from the asthma lecture that the indacaterol or the vilanterol is 1 puff daily. There is a nebulizing solution available. As before, we talked about the spacer and aero chambers, and really preferring to use inhalers if at all possible instead of nebulizing, and that the monitoring is the adherence. Are they using it as they should? If they have early stage COPD, it might just be as needed, but as they progress, they might need scheduled albuterol, or as we talk about the anticholinergic medications, scheduled ipratropium or other medications. So adherence becomes more important as we move on. And then the inspiratory drive. So how much of a breath are they able to take? They're going to need spirometry done at fairly regular basis. So you can determine, are they able to get those puffs in? Do we need to prescribe something different to help them get the medication delivered into their lungs? So again, moving on, talking about those anticholinergic medications, recall again that from the asthma lecture with how they work and the average to watch out for. What we're seeing is that ipratropium, 2 inhalations every 4 to 6 hours. It does come in that combivent Respimat that I know I talked about with asthma. That's in combo with albuterol. So albuterol and ipratropium together in 1 Respimat. It's 1 inhalation 4 times a day. And we'll see that a lot, obviously, as patients progress. Maybe they start just on albuterol or start just on ipratropium, but more often than not, you see them on that combination. And so the combination product that's available is 1 inhalation 4 times a day, which again, more convenient than 2 puffs. There are a lot of newer generation anticholinergic medications. So, up until maybe 8 years ago, there was only ipratropium. So patients with COPD had to have many doses a day, really not convenient, not good for adherence. There's been a huge explosion of newer medications that are taken just twice a day or even just once a day. So aclidinium is 1 inhalation twice a day, and umeclidinium is 1 inhalation daily. Tiotropium, which was I think it was the first long-acting anticholinergic medication available, Spiriva. If it's via the HandiHaler, which is the older device, that's with a capsule, a powder, dry powder in a capsule formulation that the patient puts into this HandiHaler and then inhales it. That's 1 inhalation a day. That is being phased out. So probably right now they're still using it and making it, but last year the company started making the Respimat. So just like the combivent Respimat, where it's a puff of medicine, that's a lot easier to get in the lungs. There's not that dry powder like with the HandiHaler. So with tiotropium Respimat, unfortunately, it's 2 inhalations daily. So that's kind of confusing. So it's not a 1-to-1. If they're given the HandiHaler, dry powder, they have to really have good breathing, good strong breathing to breathe in that capsule. That's 1 inhalation daily. If they're having trouble with that, or as that gets phased out and we use the Respimat only, that's a puff from a meter dose type inhaler, and that's 2 puffs every day. The nebulized product solution is available. Don't really see that being used much. We really want to focus in on any patient with more significant disease, trying to have them on a long-acting anticholinergic so that it's just the once daily or twice daily. That helps adherence. May need to move to one of the newer agents that is more, helps with the inspiratory, or helps with patients with a low inspiratory drive. Anything that's the dry powder, difficult for patients with bad lungs to breathe in really hard and deep. So that's where some of the newer agents are going to be to your advantage. Next up are the xanthine derivatives. That's the theophylline. So look over that information, but just remember that we talked briefly there about it having that phosphodiesterase inhibition, and that's real important because it can be, it was used quite a bit in COPD patients, and it does help because of that. The dosing, again, is the same as for asthma, the 6 milligrams per kilogram per day, using the immediate release product up to a max of 400 milligrams, so like 100 milligrams 3 or 4 times a day based on their weight. Again, you're drawing levels, so it's not very convenient. You're drawing the peak blood levels, and again, typical max dose in that 10 to 13 milligrams per kilogram. So somebody, you're typically going to see them maybe at 600 to 800 milligrams per day. Corticosteroids, nothing different as far as how they work and their side effects. So take a look at that from our asthma slides. And the same thing where they're going to be once a day or twice a day. Kind of depends on if they're just the corticosteroid, then typically it's once a day. If they're combined with the long-acting beta agonist, remember, most of those are twice a day, although there are a few that are once a day. And those have really been developed to really help patients with COPD be able to get by with once daily for all their medication needs. Need to rinse mouth out. Again, the potency. We talked about this, but remember about using their short-acting beta agonist or ipratropium, even a short-acting anticholinergic first, then using the steroid. Usually we'll see a lot more of the oral steroids being used if they end up with a bacterial or viral infection or have a COPD exacerbation. Same monitoring applies. A lot of the steroids actually now have more of a meter dose inhaler, so it is going to be a little bit easier to get the puff. They're not going to need quite as large of a huge puff as they would with a dry powder. This is a newer agent that we didn't talk about when we were talking about asthma, and that's the phosphodiesterase 4 inhibitors, the PDE4. So what it does is it's an inhibitor, inhibits activation of the PDE4 receptor site in all of the smooth muscles that are in the airways. So that results in bronchial relaxation, also decreases the immune response activation. And it has worked very well in reducing exacerbations. So it really works to relax those muscles and has been a good option. Reduced compared to placebo by 17%. In studies, it has not been used in combo with inhaled corticosteroids, but you'll see from some of the guidelines that it isn't prohibited. Some of the adverse effects that come from the PDE4 inhibitor are mainly, since it is an oral tablet, some of that diarrhea, nausea, decreased appetite, headache, dizziness, insomnia. Some of the warnings, this is similar to kind of what you saw with the leukotriene modifiers, psychiatric adverse reactions, and then the patients with hepatic disease. So if you can sort of remember both of those, the montelukast, which is the leukotriene antagonist, as well as then these PDE4 inhibitors, have some of the same warnings and precautions. This, again, with strong CYP3A4 inducers like your rifampin, carbamazepine kind of thing, can interact there. So like I said, it's a tablet, just like the leukotriene modifiers. Again, works in a totally different way, but I think it can help you remember side effects and dosing, perhaps. It's a once-a-day tablet, roflumilast. And again, we want to monitor that patients are taking it every day and that they're not having those adverse effects. And obviously checking their hepatic function every so often. Oxygen can certainly be used. You'll see it used short-term during exacerbations, much like you would for asthma, but we actually see it a lot more being used in those chronically hypoxic long-term COPD patients. The goals are the same to try to correct that hypoxemia, although certainly you're trying to get them to 90% saturation, which you're not always able to do. But as I said with when we talked about this in the previous lecture, smoking is the number one danger, can have explosions and things like that. And your COPD patient could be the one that is still smoking or kind of sneaking a cigarette. So it's real important to have a good relationship with your patients so that you can ascertain if they are smoking or if they're having some issues where they might be smoking while using their oxygen, how to work with them on that. Usually when it's long-term, they're on it continuous during their waking hours. If they are, you need to do blood gas studies at 1, 3, and 6 months of therapy, and then usually every 6 or 12 months thereafter. As you look at the guidelines and kind of think about the therapy, thinking about where the patient lies in their disease, for mild, you're going to start with a short-acting beta agonist or the short-acting anticholinergic like ipratropium, just as needed, because again, some patients don't have symptoms or it's very rare. As they have more moderate disease, it's really not, it's wide open in terms of what you use as treatment. There's a lot of choices, so this is where you can look at side effects, dose delivery, what the patient's needs are, whether you go with a long-acting beta agonist by itself, which is fine in COPD, or a long-acting anticholinergic, those once a day or twice a day versions, or you may combine them, a long-acting beta agonist and a long-acting anticholinergic. Another popular option is a long-acting beta agonist with an inhaled corticosteroid, very common, similar to what you use in asthma. You do see a synergistic response, so a better response than you would with either one of those agents alone. But there is an increased chance for pneumonia when you're using the steroids, so we just have to be aware of that. So a lot of times, because of the steroid risk with osteoporosis, potentially the pneumonia risk, we see maybe steroids not first line, maybe starting with the long-acting anticholinergic or the long-acting beta agonist. When somebody has severe COPD, you kind of are throwing the whole kitchen sink at them and using all those agents, a long-acting beta agonist and an inhaled corticosteroid and the long-acting anticholinergic. And you know that if you get some combination inhalers, that may still only be 2 different inhalers, maybe 2 or 3 puffs in a day total. So there has been a lot of advancement in the inhalers and medications available to patients to make that a lot easier to tolerate and be adherent to. Some of the alternatives that we talked about today, theophylline, again, a little messier because of the levels that need to be monitored and some of the side effects that we talked about in our asthma lecture. And then the newer agent, the PDE4 inhibitor, again, if somebody has the more severe stage C or D COPD, that certainly is an option. Managing exacerbations, we talked about that earlier with that chart that showed that with each exacerbation, we're really pushing that patient further along in their lung destruction and their inability to breathe. So we want to manage that as best as possible. When we are treating it, you'll use inhaled bronchodilators, especially the short-acting beta agonists, much like you think about with asthma. That's where the oral steroids, again, are going to come into play. And then I know sometimes previously we maybe would see a lot more antibiotic usage, but obviously with antimicrobial stewardship being so important and trying to not overuse our antibiotics, and that's becoming much less acceptable and common, really only using the antibiotics if there's true evidence of infection. Otherwise, a lot of these infections are viral, and we really just need to step up the inhaler usage and the steroids, the oral steroids to help these patients. So hopefully with this review, if you go back in and look through the asthma information and then kind of look for those differences, try to apply it to your older patient that's going to have COPD and kind of think about some of the differences in what we're using, smoking cessation, the vaccines, paramount, and then looking at the different inhaler options and the therapy options. You're not moving along a stepwise approach quite as much as you are with asthma. There's a lot more options open. A lot more things, a lot more agents have been studied in the various stages of COPD, and so there's not a clear-cut winner in what to go with. So if there are questions, please certainly let me know. But I look forward to seeing how you perform on the upcoming quiz and the exam. So like I said, please don't hesitate to give me a call or contact me with questions.